Welcome to Foxfire Focus, the podcast that brings clarity and insight to the industry's most relevant issues. Foxfire's mission is to provide the best service experience in eye care. So, we hope you enjoy what you're about to hear and that this information provides some perspective on the exciting opportunities facing our profession. For more information about Foxfire, please visit us at foxfiresg.com. Foxfire, taking care of your practice so you can manage your patients.
Hello, this is Tim Nichols with Eyes on Eye Care, a podcast about the business and the world of eye care. Today, my guest is Dr. Rod Nowakowski, and frankly, I'm a little bit flummoxed about how to introduce him. Do I introduce him as Dr. Nowakowski because of his OD, PhD degrees? He is the former dean of the UAB School of Optometry. I've known Dr. Nowakowski for pushing 50 years now, it seems like, because he taught me in school. He was one of my favorite professors. Do I introduce him as the front man of Rod and the Cones, a jazz group? Do I introduce him as an accomplished visual artist or a marksman or all the other many things that he do? Rod, how do I describe you?
You could say, here's Rod.
Okay, here's Rod. Well, the thing that really I wanted to talk to Dr. Nowakowski about is that he really is a kind of unicorn, a rare beast. I don't know if there's another optometrist that has your particular educational credentials, which is OD and PhD in genetics. Do you have an equal in that regard?
Yeah, I've kept an eye on this, and I really haven't ever encountered anyone else who had that same combination. So I'm definitely an outlier.
Yes. Now, I can understand the OD degree, why that would interest a person. Why genetics? What led you to that?
So my first job when I graduated was I joined the faculty at the School of Optometry in Birmingham, and I was director of the low vision program. We had an affiliated clinic or satellite program on the campus of the Alabama Institute for Deaf and Blind in Talladega, about 50 miles away. And I saw so many people there who had hereditary eye disease that I felt like I should know more about it, and started taking a couple of courses. And as it turned out, and that was at UAB, as it turned out, they were in the process of starting a PhD program in medical genetics, which I didn't know about when I took those first few courses. And then one thing led to another, and they got it approved, and I sought admittance into it. And so I was in the charter class for the PhD in medical genetics.
Now, what year was that?
Oh, let's see. I graduated in '89, so it was probably 4 years before that.
Okay. So back then, the whole field of medical genetics was kind of a esoterica. It was more of a curiosity. How has that changed over the last 40 years?
It's changed dramatically and unbelievably. And I guess two things really drove that. One was the Human Genome Project, where there was an effort to sequence the entire human genome. And the other was the invention of PCR, the polymerase chain reaction, which allowed us to amplify DNA rapidly. And you could take a very small segment of DNA and you could create billions of copies of that within a short period of time. And that helped drive the Human Genome Project, that technology. And those things kind of took off, and we began kind of focusing on the eye in some regards, because the eye was a readily accessible organ. You could look into it and see what's going on, and it's right there in front of you. It's not buried deep within the body. So there's been a lot of interest in genetic eye disease. Of course, I guess the most obvious reason being it's causes sensory impairment, which is a concern for everybody. Anyway, there's been a dramatic increase in our understanding of genetic eye disease, thanks to those two things, and not just eye disease, but genetics in general. Long answer to a short question.
Well, but that's a good kind of summary of that. Now, what do you think has happened to our understanding of eye disease versus genetic eye disease in this time period? Like, 30 years ago, we might have seen something and said, that's just an occurrence. But now our understanding may have changed that it actually has a very deep genetic basis.
Yeah, I think the biggest change is that we now recognize there are two types of diagnosis. One would be the clinical diagnosis, and the other would be a molecular diagnosis. And I'll use for an example, retinitis pigmentosa. We know that, well, when you and I were in school, we thought of it as one disease. Then we started thinking, well, wait a minute. We knew it could be inherited in 3 different ways: X-linked, dominant, and recessive. So we knew there was more than just a single disease. And then now we know of over 3,000 different mutations in about 80 genes, all of which cause what you and I would clinically call retinitis pigmentosa. So you could, at the molecular level, say we're really talking about 3,000 different diseases at the molecular level. So I think the big change in our understanding is that it's not as simple as we thought it was, and that's a lesson I learn almost every day.
Well, talking about your everyday, what is your current position?
My current position, my official title is Director of Genetic and Advanced Diagnostic Testing. And the advanced diagnostic testing part of the title refers to electrophysiology. Genetic testing is something we'll talk more about, I'm sure. And that's at Vision America, a multi-specialty medical surgical eye care referral center located in Birmingham. And I should say, you didn't ask, but I'll volunteer. I have no conflicts of interest, no financial interest in anything that I might mention today, like Vision America or any kind of products or laboratories or anything like that.
Okay, thanks for making that clear. We're just poor old guys doing the best we can, right?
What that basically says is nobody wants to pay me for anything.
Well, all right. So in your current position, what kind of work are you doing in the field of genetics, and what are you doing for patients and people that refer into you in the field of genetics?
Yeah, so we're a referral-based clinic. All of my patients are referred from a network of primarily optometrists, but also our own MD surgeons. So if someone suspects somebody has a genetic disease, they understand that there's a role for genetic testing, they refer to me. I see the patient, this initial consultation, kind of do an assessment, and then determine if genetic testing has a role for their care. If it does, I explain that to them and explain to them how it works. Order the genetic test. When the genetic results come back, I want to elaborate on the results if we get a chance, but when the results come back, then I meet with that person again, and that's for a counseling session. And I explain to them what we found, what it means, and what we're going to do with it. I will say this, it sounds like if there's 3,000 mutations that all cause RP, we must know about all of them. We probably don't. Sometimes we do genetic testing and we don't get an answer. And then I talk to them about other tests that we might do, or testing again at a later date when our technology improves and when our understanding improves. But as part of that counseling session, I also tell them about clinical trials and say this may or may not be something that interests you, but if we are ever going to have treatments for genetic disease, genetic eye disease in particular, and we do have one now, it's going to come out of clinical trials, and you may be interested in participating in a clinical trial And I show them how to go to a website and search for clinical trials on their own. So it's not just telling them this is what we found, but telling them this is what we can do about it. And maybe be in a clinical trial, and maybe there will eventually be a FDA approved therapy that you can participate in.
Now you mentioned the doing the testing. Explain how the testing actually works, the genetic testing. Is that cheek swabs, blood draws? How does that work?
Yeah, initially it was a blood draw and or a tissue sample. There's been a pretty good improvement over the last few years where we can now do a cheek swab for almost all genetic tests. And the lab will often say we prefer blood, but if you get a buccal smear, a smear inside the mouth on the cheek, we can do the test on that. So we do that in the office, or I see some patients by telemedicine, and I give them the opportunity to either come to an office if they want to, or the laboratory will mail a kit to their home, and they can collect their own sample and put it in a prepaid FedEx mailer and send it back to the laboratory. Much to my pleasant surprise, I don't think there's been one incident of a person who could not do that. It's a relatively simple procedure, but I'm laughing because I've had some interesting experiences with that. But it works quite well.
Good. Pretty much, if you can brush your teeth, you can submit a genetic sample.
Yeah, and brushing your teeth is probably a good idea, but we tell them don't do it before you do the test because,
of course, yeah.
And I tell them nothing to eat or drink for 30 minutes before you collect the sample.
Mm-hmm.
So one type of sample is, it's not a cheek swab per se, it's saliva.
Yeah.
The person spits in a tube.
Yeah.
And I'm watching this guy do it, and it's brown. And I said, "Whoa, wait a minute, what's that?" I told you not to eat or drink. He says, "I didn't eat or drink." He was dipping snuff. So he had brown saliva. So we started over. We started over on that one.
Turns out he's got the genome of a tobacco worm or something.
Yeah. Or if he had a ham sandwich, who knows?
Well, so you mentioned that the clinical trials right now are aiming at determining more about the conditions for targeted therapies. And you mentioned there is one FDA-approved targeted gene therapy for a genetic eye disease. Elaborate on that a little bit.
Yeah. So the name of the drug, and we refer to it as a drug, even though it's introducing a virus or a virus carrying a gene into the body, is Luxturna. It was created by Sparks Therapeutic. It came out of a clinical trial, and it was specifically directed towards Leber congenital amaurosis. Mm-hmm. All these things are rare, but that's I wouldn't call it so rare that you shouldn't pay attention to it. It's common enough and it's severe enough that it's worth paying attention to. So the idea was, well, okay, they've got a gene that's not working right. Could we put a gene that is working right inside the eye, and would that correct the problem? So the clinical trial was designed to do exactly that. A normal gene, and it's specifically, there are several genes that cause Leber congenital amaurosis. This one is RPE65. So they created that gene synthetically. We had, I say we, I mean the genetics world community, knew the sequence of nucleotides in the gene, and it could be synthesized in a laboratory. And then the trick is to get it into a virus that, if you put the virus in the eye, we all know what a virus does well is invade cells in the body. So the thought was, what if we could get this thing in the back of the eye, in the retina, in the RPE, where the problem originates? What would happen? So it turns out that the gene could be introduced, could be put in a a viral vector, could be introduced into the retina through an intraocular injection, and that it would actually function back there. So it's a case of what I'll call gene supplementation. It's not a fix. The gene that's not working right is still there. But now we've got a gene that is working right, supplementing that one. So it has met the criteria of the investigators in terms of getting some improved vision, not a cure, but improved vision. And that's been reported by people who have received it. So the FDA's, and there were no adverse effects, minimal from the injection, inflammation, things like that. So the FDA approved that treatment. So that's the one approved treatment we have for genetic eye disease, Luxturna, called a drug, but it's a gene and a viral vector injected into the eye.
All right. Now, put on your rose-colored glasses for me, and I want you to look 15 years into the future. Private practice optometry, the field of genetics, which was something you learned kind of like anisoconia in optometry school, that you kind of shoved to the side and said, yeah, I may need that one day, but it's not really going to be a part of my day-to-day. Has that moved out of the closet up into the forefront of practice 15 years from now?
Sure. We're in the genomic era right now, and any practitioner can order genetic testing right now. They may say, I don't necessarily want to do that. Well, they can refer to some place that does do that, but they can get it done. And once you have that information, you can look for clinical trials, or you can actually, most laboratories that I've been working with have access to genetic counselors. So you might say, well, I'm not comfortable knowing what to tell the patient once I get their results, unless they're very straightforward. They can take advantage of these genetic counseling entities, and they will help you or help the patient find clinical trials and interpret the results. So looking down the road, I don't think not in 15 years, we won't see a case where a practitioner does genetic testing in the office. Although I think eventually we'll probably get there, but they certainly can get the genetic testing done in the private practice setting and help the patient get into a clinical trial or get an FDA approved gene therapy. So it can be done now. It'll be done more easily, I'm sure, in 15 years, and it'll be more accessible and more affordable. Price is a big issue right now.
Yeah. Do you think it's reasonable in any stretch to say there might be a day in which I diagnose a patient with glaucoma clinically, but I realize that there are a number of mutations that would lead to that clinical diagnosis? So I have them tested, and I find that they have a particular, what I would say, genotype, but you say genotype, is that right?
No, genotype, I agree.
Genotype, all right. Genotype. Oh yeah, I say genome and you say genome. So I guess that's kind of like the Rube's way of saying potatoes versus potatoes.
Yeah.
Anyway.
I don't know if it's right or wrong, but most people understand me.
Okay. So I test my glaucoma patient. I find they have a particular genotype, and the research has indicated that for this particular genotype, this is the appropriate drop, or this is the appropriate treatment, or this is the appropriate means to deal with their glaucoma, versus the way we do now, start with A and work through Z and try to find something that works.
Yeah, so you're talking about the field of pharmacogenetics.
Yeah.
And that is, if you said to me, what all other things might we see in 10 or 15 years, pharmacogenetics will be a big one. And glaucoma would be a great example, where if we knew some drugs would work for some genotypes better than others, and we do have that for other conditions, not for glaucoma, that would be ideal. We would not have to waste time trying things that we know won't work or that might even have an adverse effect. So I see that as a definite future occurrence. And it may be, we may not have to know that there's a genetic cause of the glaucoma, but we may want to know that there's a genetic facilitation
Mhm.
of a certain medicine treating a disease, whether it's genetic or not.
Yeah.
So yeah, so we may not care what their actual genetic cause of the glaucoma is, but we will care if the medicine that we want to are considering or which medicine we might want to prescribe for them works.
And that's being done right now in other fields of medicine, is it not?
It is, cancer is one of the big ones for sure.
Absolutely. Well, we're running close on time here. Is there anything else about the field of genetics that I didn't ask that you'd like to say?
Yeah, I'll try to be brief, although it may be difficult, but I'll try. But a lot of people have been resistant to testing. They say, well, why bother? There's nothing we can do about it anyway. Not true. To the patients, for many of them, you can bring an end to what they call a diagnostic odyssey, where they've had something wrong with them that nobody can tell them what it is. And we may get an answer through genetic testing. We may not be able to treat it, but they find comfort in no longer being a medical oddity. They refer to a sense of empowerment,
Mhm.
that they now have a better idea of how they can help manage their condition. A sense of not being an oddball that people look at and say, well, they've got all these complaints, but we can't find anything wrong with them. Well, we may be able to do that with a genetic answer. So my encouragement to the private practitioners is get involved in genetic testing right now. We want to get the results right now, because if a clinical trial comes along, they may say we're going to test 20 people, and you may find out they've already got 19. You don't want to wait 2 or 3 months to get an answer to a genetic test, and some can take that long. Have the patient ready to go. If they want to get in a clinical trial, they've got what they need, because it'll be specific to their genetic test in most cases. So get involved now. Give them an answer if you can, and get them ready to be either treated or participate in a clinical trial.
Right. And to be in these clinical trials, you have to know which one of those 3,000 RP genetic varieties you have in order to be enlisted in that trial. So getting tested at that point is going to take too long. You need to have your diagnosis ready when you go into the trials. And is that correct? That's my understanding.
Correct.
Yeah.
Anything that involves gene therapy, their first question will be, have you had genetic testing? And what can you share a copy of that with us? And if you ask me for one other thing, I hope we'll see, and that'll be gene neutral therapies, where they say, okay, all of those things that cause RP, we know they make photoreceptors degenerate. Could we regenerate photoreceptors? We don't care what the gene cause was. If we can give you back functioning photoreceptors, that's coming also,
Yeah.
a type of stem cell treatment.
Or with RPE and macular degeneration.
Yes.
Okay, wonderful. Absolutely. Well, Rod, over the years, you have taught me so many things, low vision, genetics. But one of the things that I have enjoyed the most is your very dry sense of humor. So take us out with a one-liner.
All right, I'm going to take you out with a piece of genetic counseling. If your parents did not have children, you probably will not either.
Oh, such wisdom, such depth of wisdom. Rod, thank you so much for your time. What a pleasure to visit with you, and we really do appreciate your input here.
You're welcome. I appreciate the opportunity to get the word out, and something I feel strongly about.
Great. All right, Eyes on Eye Care. Thanks for tuning in.